I think we'll give it a minute for the attendees to roll in, and then I can start the session. All right, so I think the number of attendees is stabilizing, so I think we can go ahead and start the session. Good evening, everyone, and thank you for tuning in to this evening's SSAT webinar on the General Surgery Certifying Examination Preparation, the Mock Oral Scenario Series. This is slated to go from 5 to 6:30 p.m. Eastern Time, and we'll try to stay on time. So due to unforeseen circumstances, Dr. Altieri and Dr. Adams are both not available today. They would love to been here, but I'll be moderating in their place. And my name is Zivan Fong, and I'm a surgical oncology fellow at Massachusetts General Hospital. We'll go through each of the mock examiner and examinee's introduction as we get through the mock scenarios. So really quickly, some house Zoom rules. Please mute your microphone when you're not speaking, so we keep the background noise to a minimum. If you have any questions, please list them in the Q&A section at the bottom of the screen, and I'll go through them at the end of the webinar. And a quick PSA about SSAT. The SSAT is one of the oldest surgical associations dating back to the 1960s, when it was originally an association for colon surgery. The society's goal is to be at the forefront of the science and practice of GI surgery and to foster a community of GI surgeons advancing the field to improve the multidisciplinary care of patients with GI disorders. For most of our audiences today, the price of a membership is a mere $20. And if you're a medical student in the audience, you're way ahead of your time and good for you. And your membership is priced at $20 as well. And for that small price, you get free access to the contents of the society's parent journal, which is JOGS, which is the Journal of GI Surgery. You also get discounted registration prices to the annual Digestive Disease Week and be able to apply for the many awards and traveling fellowships on top of leadership opportunities like being involved in committees such as ours. For all of you who register for the session, a copy of the webinar recording will be emailed to you. It is also posted on our SSAT's Resident Corner website and uploaded to the SSAT YouTube channel. So please subscribe to our channel to receive updated postings from the account. This is the scheduled events for today, but before we begin, I have to note that these mock scenarios are not actual case scenarios on the boards, and they are not endorsed by the American Board of Surgery. Dr. Caitlin Hicks is getting off a flight later than expected, so we'll move her case scenario to the bottom. So without further ado, we will start with Dr. Evangelos Messeris from Beth Israel Deaconess Medical Center and Dr. Kwakman from the University of Texas, San Antonio. So I'll stop sharing my screen and maybe Dr. Messeris and Dr. Kwakman can take over.
Great. Welcome to your exam. So I'm presenting with a 46-year-old male patient that comes to the emergency department with a 2-day history of severe abdominal pain. The patient is complaining of pain 10 out of 10. The emergency department has evaluated him. They're gravely concerned about his exam, and they're calling surgery immediately. How would you proceed?
I would start with a dedicated history and physical exam, just highlighting his history and any history of abdominal problems, surgery, as any other comorbidities as well.
So he's healthy, he's 46, healthy, no past surgical history, no medication, no allergies, no family history.
And what do I encounter on physical exam?
What are you looking for?
I would do a physical exam of his abdomen in this case, and then briefly a cardiopulmonary exam.
Cardiopulmonary, his clear sounds bilaterally. Heart rate is regular but very high. And on exam, you touch his abdomen, and he immediately guards and says that he's very tender.
Is there any focal area that's worse than other, or is it diffuse?
It is diffuse.
Okay. And do I have a set of vitals on?
So the nurse just came back and says heart rate is 130, blood pressure is 120/60, temperature is 101, and oxygen saturation is 94%.
Okay. And in his history taking, other than the past medical history and the surgical history, is there anything in his history of presenting illness that is guiding?
Everything that was given to you when we introduced the scenario, which is pain, 8 out of 10, started 2 days ago.
I see. So then I would get broad labs on him to include a CBC, a CRP, and a CMP. I would give him pain medication and start him on fluids. And I would plan to perform a CT scan of the abdomen with IV contrast.
So white blood cell count comes back at 25,000. Hemoglobin is 11. Platelet count is 500,000. CMP shows a creatinine of 1.1. Otherwise, no other big abnormalities. They're about to take him for a CAT scan, but they call you that now his heart rate still remains in the 120 to 130. And he is now, blood pressure is 85/60.
I would give him a fluid bolus to increase his blood pressure. Ideally, if the patient responds to fluids and he's not a transient responder, I would be able to get a CT scan that will be ideal. But if the patient does not respond and his exam is still as concerning as it was before, then he will likely need an exploratory laparotomy if he does not stabilize with fluids.
So the exam is the same, and you give 1 liter, and the blood pressure is 85/55.
So then the patient is not stabilizing with fluids. Considering the physical exam, there's a likely source in the abdomen for his hypotension and tachycardia, and his elevated white blood cell count points toward a septic source in the abdomen. So I would take him for an exploratory laparotomy.
Right, patient's going to the operating room. Can you describe what you're going to ask from your team in regards to positioning and prepping?
So a patient would be supine by both arms out. I would have the patient prep from the groin towards the nipples. I make sure that anesthesia is aware of his condition prior to taking the patient up, and would tell them that the patient is not stable. Would likely they would need a central line as well as arterial line, and then start prepping vaping. Make sure that the bars are available to place poke halters and pumps and retractors.
You open the abdomen, and immediately fecal fluid is present. You perform an exploration, and you find a hole in the sigmoid colon. Looks like a particular disease. Nothing else is abnormal on exam for the rest of the abdomen, other than that there's stool everywhere. How do you want to proceed?
I would wash out the abdomen. I presume we already explored everything, and so then I would proceed with the sigmoidectomy to include the diverticular disease and any diverticulae of the sigmoid.
Okay. Can you describe how you're going to do that?
Yes, depending on the planes, but I would, in an open procedure, I would perform a lateral to medial approach. So I would mobilize the lateral attachment of the sigmoid, starting with the white line of pole, and mobilize the sigmoid medially, as well up to the splenic flexure. I would make sure I identify the ureter while doing in this process. Subsequently, I would do a closed colon resection. So I would identify my points of resection. I'd staple it with a GI stapler, take my mesentery close to the colon, and then I would decide whether this is going to be a Hartmann's procedure / what I would be able to anesthetize the patient depending on the stability of the patient.
So sigmoid colon is out. Blood pressure is 120/60. Heart rate is 110.
Is the patient on any pressors at this time?
The consult said, "Oh yeah, I forgot to tell you. The patient is on neosynephrine now, a low dose neosynephrine."
I see. Considering the patient is then not stable or only stable with pressors, I would perform a Hartmann's procedure and give the patient an colostomy with a rectal stump.
Okay. You close the patient. Patient goes to PACU, remains on pressors overnight. The next morning, good urination, maintaining well. Vitals are normal, actually. Heart rate has normalized, blood pressure is up, and patient's doing well. By day 2, you feed the patient. On day 3, while you're doing rounds, they immediately call you that he's suddenly now hypoxic with oxygen saturation in 78 with no oxygen on, and tachycardic in the 130s.
Mhm.
You arrive at the bedside. How would you proceed?
So the patient is currently setting 70%. You said, sir?
74.
Okay. I would immediately administer 15 liters of oxygen through a non-breathing mask. I'd get a set of labs at an EKG. I'd be concerned for possible cardiac as well as a PE, but I'd like to get him more stable before getting any further diagnostic workup. If he's still setting poorly, we need to be transferred to the ICU.
So you put the oxygen on the non-breather. He's 85% now, 74. Still appears dyspneic, still tachycardic.
I would transfer him to or if he's not already in the intensive care unit, I would, if he's still tachycardic and hypoxic, he will probably need to be intubated at that time.
You intubate him, you move him to the ICU.
Does his oxygenation improve at that time?
It did not.
Let's get and did the EKG demonstrate anything significant?
Some T elevations.
Okay. I get a chest X-ray. They need to know if the patient is appropriately intubated and whether there are any large problems.
Both are normal. They're notifying me we have to stop because of time. But great, thank you very much.
Thank you.
So Dr. Mataris, you're going to move on to giving Dr. Quackman a little feedback or going through a debriefing. We have a couple of minutes, right?
Right. You did very well at the beginning, managed the patient well. On the history, you need to ask a little bit more about, the abdominal pain, the 8 questions we asked about pain, severity, radiation, when did it start, whether it's colicky or I think the usual 8 questions for the pain. History fine. Physical exam, I would have started with the vitals. There are 2 types of patients you're going to have, and I think you should clear them from the beginning at the board. The one is, am I dealing with an emergent patient or am I dealing with a non-emergent patient? If you're dealing with an emergent patient, either in the emergency department, the floor, or the thing, first of all, you need to assess stability. So before you ask history, get the vitals, see if the patient is stable. If not stable, start airway breathing, circulation. If stable, you can go down the road of the HMP. You recognize the need for the operating room. So you didn't cross that line to go for the CAT scan. That would be a bad thing to do. You went into the operating room. I had to push you a little bit to give me the operation, meaning to describe. And I'm saying that because the key here, you said you could do a sigmoidectomy. The examiner is looking to find out how you're going to do it. And he's looking to find out if you're going to check for the ureter and if you can do the safe maneuvers in the panic that you found the stool. And you did everything correctly. Then you proceeded, decided that the Hartmann is the right decision, and that was the right decision. On the floor, the only thing I would have changed, and that's on the exams, is the fact that I would have started heparin. If I'm suspecting, you said I'm suspecting PE, patient is remaining unstable, and the major finding is only hypoxia. On physical exam, I would have started the heparin drip at the bedside upon transfer to the ICU, so you don't delay treatment. I think overall you would have passed the room without any problems, but just be aware of the heparin, because that's a key point on that exam.
I appreciate it. Thank you.
Perfect. Thanks, Dr. Maceras, and thanks, Dr. Kwakman. That was a great scenario. We'll move on to our second scenario, and it's going to be Dr. Moses Kedan. He is a HPB surgical oncologist from Mass General Hospital, and Dr. John Harrison, who is the chief resident at Mass General Hospital as well.
All right, John, nice to meet you. My name is Motaz Kedan. I'm one of the examiners here, and today we're going to be talking through a case here. So this is a case of a 55-year-old man who has slowly, over a period of time, developed increasing dysphagia to solids more than liquids. I'm just going to say, just for the purpose of this, HPB, this is actually a little bit more GI than HPB per se. HPB questions tend to be pretty rare on this exam and usually pretty straightforward, but, you know, this is all sort of, you know, somewhat connected. All right. Other than that scenario, there's no other past medical history of relevance. He has some remote history of GI cancer that he can't tell you much more about. Not on any medications. On examination, he appears pretty thin and wasting, and you can see his rib cage is pretty prominent. Abdominal examination is unremarkable, and there's no any sort of, you know, fancy nodes or anything like that to pick up on exam. Go ahead.
Okay. Am I meeting this patient in clinic, or am I meeting this patient in the emergency room, or as a?
You're meeting this patient in the office. This is an elective new visit in the office.
Okay. So I would just characterize a little bit more about the timeline of the symptoms, and then just sort of when any other associated symptoms that he might have in addition to sort of this principal finding of dysphagia.
Nothing else. It's been going on for about 2 months, and he tells you that he's been losing a little bit more weight. He thinks that he's lost about 10 pounds over the last 2 months. Not much more.
Did he notice that there was any change in the dysphagia in the sense that he was tolerating more solid food first, and then that became more challenging, or liquids first, and then that became challenging, or vice versa?
I'm not sure what you mean, doctor. It's just been getting worse over the last couple of months. It's just mostly solid foods. I'm struggling. Sometimes I feel like it's getting stuck up here.
And he's had no history of any sort of upper GI pathology in the past, no prior surgeries. Okay. So at this point, you know, I'm curious as to ways to work up his differential a little bit more. Certainly with a patient who has dysphagia and weight loss, those are sort of alarm findings that would sort of trigger that this could be, you know, a malignancy that's been undiagnosed. So I think that at this point, I just characterize, if possible, a little bit about his sort of oncologic history in any detail, but it sounds like that might not be possible. And then just complete the physical exam, which we already got most of that information largely unrevealing. So I think at this point, then it's about working up this in more detail. And I would begin most likely with an EGD to evaluate if there's any obvious pathology in the esophagus, since I'm suspecting that there's something either in the esophagus at the GE junction or in the upper GI tract.
Okay, is there anything you'd like to get while he's in the office just now?
It'd be good to have a set of labs for him.
Okay,
so
what would you like?
I think it's important to understand sort of his nutritional status. So I think a full sort of CMP that includes electrolytes, albumin, a pre-albumin, LFTs
Everything
in
looks
general.
normal on that. Is there anything else that you'd like?
CBC would be good in this case, just to know if he has any anemia.
Okay, his
could have
hemoglobin is
an upper GI.
10.5.
Yeah, which could be either a reflection of him having some subacute bleeding, or it could be related to sort of malnutrition, which sounds like has been smoldering over the last several months. And then I think that it would be good to have a set of tumor markers for him too, just with an oncologic history. So
Okay,
CEA
so you
and
get
CA19-9.
CEA is elevated at 20. I assume that's probably what you wanted. You check a CA19-9, that's normal. Okay, so you're going to proceed with EGD, you said. The gastroenterologists are all out on this huge golf tournament that they didn't invite you to. So tell me how you do that.
So for these patients who are going to have an EGD done, this would be something I would do at a surgery center, or, you know, as an outpatient procedure in an operating room. So I'd have the patient brought into the hospital, preoperatively evaluated by the anesthesia team. It doesn't sound like he has any comorbidities that would preclude him from having sedation. So I'd have this patient brought to the OR, positioned probably with left side down, and then proceed to do the esophagoduodenoscopy. So I would insert the scope very carefully, probably with a little bit of jaw thrust, in order to get the scope past the sort of pharynx and into the esophagus to then evaluate the mucosa of the esophagus.
Okay, so you're in the
um,
stomach now, you've insufflated. Are there any particular maneuvers you try and do while you're in there?
So if I'm in the stomach and I don't see anything grossly abnormal, I'd want to retroflex this patient just to evaluate the G junction and the cardia.
So on retroflexion, you notice that there's a large, what appears to be about a 4-centimeter mass that's about 5 or 6 centimeters away from the GE junction. It looks like it's fungating. It has a little bit of ooze on it, no major bleeding or anything like that. You get a biopsy, it comes back showing invasive, moderately differentiated adenocarcinoma. What would you like to do next?
So in this patient, is this only a biopsy, or is this is not going to have a EUS and FNA, presumably? So I don't have a lot of information other than the tissue. So at this stage, I think this is a patient who I'd refer to sort of for a multidisciplinary evaluation, and then likely stage this patient to make sure that there aren't any other, or to understand exactly sort of where this patient is, if they're more of a locally advanced case or if they're an upfront resectable case. So I think that this needs some more information from a multidisciplinary discussion and a further workup.
So what would you like to order next?
So for these patients who have a proximal gastric or GE junction tumor, it's very important to get a CT chest as well to evaluate for any sort of lung metastases, lymphadenopathy. I'd also do a CT abdomen pelvis to stage the remainder of the abdomen and look for any sort of lymph nodes or any sort of extension beyond the
okay, so time is
well.
running short at this point. So just to let you know, the CT chest is clear, the abdomen is clear, but you see a large bulky mass with a lot of regional lymphadenopathy. What would you like next?
Yeah, so this is a patient who I'm suspicious is going to have locally advanced disease. So a multidisciplinary discussion that involves oncology. So this patient can likely be entered into a neoadjuvant regimen, but I would want them to also have a GI doctor do an EUS and an FNA to get complete staging done, specifically to know if there's nodal disease. But this is a large tumor, so it's falling into sort of the T2 and above category. So I'd refer this patient for neoadjuvant treatment.
Okay, so the EUS confirms that it's the locally advanced tumor and the node is positive. The regional nodes are positive for cancer. They sample a couple of them and they're both positive. So the chemotherapy is started first. They decide to do neoadjuvant, and then they get another scan. It looks like there's been a good response. What would you like to do next?
So if the patient has a good response to neoadjuvant treatment with this disease, I would plan to do a resection for them. It is in the proximal stomach, so I think that surgical planning is very important here with approach, whether that's through a thoracoabdominal incision or it's going to be through a midline, upper midline laparotomy, in order to appropriately get a margin for this patient and then perform an anastomosis. It's going to have a good chance of healing.
And what is the operation that you'd like to do?
So this tumor was within 5 centimeters of the GE junction, if I remember correctly.
It's about 5 or 6 centimeters. That's fine. Yeah.
Yep. So I think for this patient, a laparotomy with a total gastrectomy and a Roux-en-Y esophagogygenostomy would be the treatment of choice for this patient.
Okay. And just give me a couple of pointers of how you do this operation again. So through a midline laparotomy.
Yep. So this is going to be through a midline laparotomy, dissected down through the anterior abdominal wall. Exposure is going to be sort of facilitated with either a Thompson retractor or a Buchwalter retractor. Once I have the stomach and the lesser set or the pars flaccida visualized, I would open pars flaccida and begin sort of dissecting around the left gastric and doing a sort of lymph node staging as we sort of go. And then as that's done, sort of work up to the esophagus and the diaphragmatic hiatus, dissect there, just fully mobilize around the esophagus, ensure that I think I'll have good margin sort of on that proximal transection point, and then continue to work around the greater curve, lesser curve, and then take the short gastric. So it's going to include sort of a circumferential dissection of the stomach as well as a complete a regional lymphadenectomy. So this would include sort of all of the gastroepiploic nodes, left gastric nodes, and sort of the more retroperitoneal nodes sort of at the D2 level. And so once that's done, the stomach can be transected, leaving sort of a duodenal stump. the esophagus can be transected, and then I'd proceed with the reconstruction.
Okay. So you do the operation, the patient does fine. You take the left gastric pedicle as well and the mobilization of the total gastrectomy specimen, and then you proceed with a D1 lymphadenectomy. So just very quickly to finish the scenario, because we're out of time, you're called to the PACU. The patient is noted to be hypotensive by the PACU nurse. His systolic blood pressure is 60 and diastolic is 40. Can you just give me a few diagnoses? I don't want the workup, just a few diagnoses of what could be going on here, just a differential, please.
So massive bleeding would be one thing that I'd be concerned about. A duodenal stump blowout would be another thing that I'd be very concerned about.
Okay, so sepsis, potentially, early sepsis, okay.
I'd also be concerned about a massive PE in this patient with the cancer history. Those things have sort of early catastrophic sort of outcome.
Okay, anything
heart
else?
Attack as well.
Okay, so an MI, anything else? You look up and you notice that there's a central line sitting in the neck of the patient that the anesthesiologist managed to sneak in.
Yeah, an air embolus could certainly cause a massive sort of cardiopulmonary event as well.
Anything else on the cardiopulmonary front? Okay.
Attention pneumothorax or something. Excellent. From the central line going in.
Yeah. All right. Thank you. All right.
Thank you very much.
All right. Thank you, John. So I'll just go ahead and are we doing the feedback now, Z? Is that right? That's how we do it?
Yes, you can do the feedback now. Yeah.
Yeah. Okay. All right. Thanks very much, John. So John, obviously you're very articulate. You're very thorough. You're very polished in how you speak. You've got great poise. The speed and the tempo is perfect. I'll give you now the feedback of generally what I tell people when you're doing sort of the board exam. First of all, you've got to manage to control how much you talk a little bit, because you also have a very limited amount of time and they need to get the questions out, basically. So, first of all, don't forget this is a tennis game. You speak, they speak. You speak, they speak. And try not to kind of, over kind of define what it is that you're trying to say. I'd like to get a CBC. What do I find? The hemoglobin is down. Okay, what else would you like? I'd like to get a CEA and CA 99. Okay, how would you stage this patient? I'd like to get a CAT scan. This whole thing about multidisciplinary and saying it over and over again is basically not getting you somewhere specific in a surgical exam. I always tell people, don't forget that this is a surgical exam, not an HNP exam. So you want to try and get to the operation as fast as you can, and being methodical and organized in the way that you were as well. Typically, I'll just give you some generic advice. Choose a path and go with it. Yes, there are multiple ways that you can address breast cancer, mastectomy and lumpectomy or radiation, but what would you do? And just give one, be precise, and go with it. It's okay to go back. There's nothing wrong with going back and changing. By the way, I forgot that I needed to get a PET scan and a diagnostic laparoscopy in this situation. These are the only couple of things that I would add to a gastric cancer situation, because each of those will give you probably an additional 10% yield of findings that you wouldn't have had otherwise. They'll tell you sometimes at the beginning of the test that the HNP is given. I'm still reluctant to go into a test and not do any HNP. We did a lot of HNP, probably more than we needed to, given what I had given you. So I would say, having done a complete history and physical, I would next start with labs. Is probably how I would have started that scenario. Make sure that you have your pieces down on how you would start a scenario. There's always the sick patient or trauma patient, ABCs, and then there's the office patient. Having done a full HNP with the information that you've given me, I'll just make sure nothing else additional, maybe one or two quick questions, and then move on. Don't forget, you are the expert. You're the one who's been studying. So you're the one who knows all the stuff about everything. So be confident in this exam and talk well. I mentioned that time goes by fast, and this is a surgical exam. Don't worry about operating. Don't worry about opening patients. Don't worry about taking back patients is always the generic advice that I give. The wound vac, you're not going to have to manage that. This is just an exam, if you have to do that or whatever it is that you have to do. Know every operation in about 5 steps. So total gastrectomy basically is going to be getting into the lesser sac, short gastrics, left gastric pedicle, and then you've got the reconstruction, and then you've got the lymphadenectomy, D1 or D2. If they want to ask you additional questions on how exactly you open the gastric pedicle or whatever, they will ask you that, all right? Describing retractors and things like that, I think, is beyond the scope of what you need to be doing in the time that you have. And then the final thing that I would just add, just as helpful advice, is always summarize. And I think you did that as well, which is push back and say, all right, well, it sounds to me like you're describing the case of a locally advanced gastric cancer that is non-metastatic in a 55-year-old. At this point, I would do the following. This is advice that Murray Brennan used to give us, which is really helpful. And so that way, the examiners know this person knows what they're talking about. They can pull back and allow you now to run with the stem of the question a little bit more. I'm pretty sure that would be a passing exam, and I think the you did very well. As I mentioned, the only thing is I'd try and sort of to kind of let the tennis game happen a little bit more would be my constructive feedback here. Thank you.
Thank you.
Thanks, Dr. Kadan and Dr. Harrison. That was a really good session. And I think your debriefing basically answered two really good questions in the Q&A about the staging laparoscopy before neoadjuvant treatment. We'll move on to our third case. We'll have Dr. Medica Tashoma from MD Anderson Cancer Center giving the case, the mock case scenario to Dr. Connor Chick from Brooke Army Medical Center.
All right. Hi, welcome.
Thank you.
So you're in the breast clinic and you're seeing a patient today. He's a 62-year-old man. He has a breast mass that he's noted for the past several months in the subareolar position. And he tells you that he hasn't noticed any other symptoms. So no pain, no nipple discharge, no skin changes. He's really otherwise healthy. He does have hypertension, and he also was previously treated for prostate cancer a few years ago. On exam, he does have mild gynecomastia. He does have a firm, irregular appearing about 3 centimeter mass in the right subareolar position, but otherwise the exam is unremarkable. No lymphadenopathy, nothing else. So what's your next step for this patient in terms of his workup?
So next I'd proceed with imaging. So I would obtain a diagnostic mammogram and an ultrasound.
And so you obtain a mammogram of the bilateral breast and also an ultrasound on the ipsilateral side of the breast and axilla. And these studies do show a mass. It measures about 3.5 centimeters, spiculated in appearance. There's no suspicious lymph nodes, and you have like a wonderful radiology group. They just go right ahead and biopsy the mass for you, and you get the results. So it shows an invasive ductal carcinoma, grade 2. ER positive, CR positive, HER2 negative. What would be the next step for this patient for his treatment option?
So options for this patient. So he has a hormone receptor positive, sounds like T2 tumor and is clinically node negative. And so I would recommend a mastectomy. And I assume on an exam, he's clinically node negative as well.
That's right. He's clinically node negative.
Okay.
What other treatment options could you offer him?
So other treatment options could include, could offer him neoadjuvant chemotherapy, and would benefit from endocrine therapy as well. So aromatase inhibitor. Given that he does have localized disease and has gynecomastia, my upfront recommendation, as long as this wouldn't be cosmetically disfiguring, would be mastectomy.
Okay. Do you think that if he, let's say the patient asks, he's had an aunt with breast cancer, she had a lumpectomy. Is that an option for him? A lumpectomy with radiation?
So I would say it is an option for him. However, given that given his gender, honestly, he's not going to have a whole lot of other breast tissue in the area. And I would say that surgically speaking, the difference between lumpectomy and mastectomy for him is relatively minor. And I think we'd be able to get him an oncologically equivalent result without the addition of radiation. And again, a relatively similar operation.
Okay, great. So you present the patient at the tumor board and they agree to do surgery as the first step, like you had said. And the patient does take your recommendation to do a mastectomy. What would you recommend for management of the axilla for this patient?
So I would perform a sentinel lymph node biopsy at the time of surgery. And so I would use dual tracer, so an isosulfan blue, as well as a radio tracer injected underneath the nipple prior to beginning the mastectomy.
Wonderful. And are there any, and can you describe a little bit more about the sentinel node operation?
Sure. So if possible, I would approach the axilla. So I would perform the mastectomy first, and if possible, would approach the axilla through the same incision. Otherwise, I would make an incision along the hair-bearing area of the axilla. I would enter the clavipectoral fascia and attempt to begin to identify any sentinel nodes using a radiotracer probe, as well as looking for any blue nodes. I also would palpate for any pathologically abnormal nodes as well. So I would dissect around those lymph nodes that are positive for tracer or for dye, or that feel abnormal, ligating lymphatics as possible. And then I would continue harvesting nodes until I have a node with a radiotracer count of less than 10% of the highest count that I find.
That sounds perfect. So you do the mastectomy and sentinel node biopsy, and it turns out that you find 4 sentinel lymph nodes, and unfortunately 3 of the lymph nodes have cancer. So what would be the recommendation for the patient now?
So at this point, I would want to make sure that I've fully staged his cancer prior to proceeding with adjuvant treatment. After reviewing the pathology with him, I would perform a focused history, specifically asking about any neurologic symptoms or any new bony pain, and would obtain focused imaging based on his symptoms. I would also, at this point, recommend him for adjuvant chemo and endocrine therapy. And then I would also make sure that he has a discussion with radiation oncology to discuss the utility of post-mastectomy radiation.
Okay, great. So let's say you do the staging, so you do a CT of the chest, abdomen, pelvis, and a bone scan, and you don't find any metastatic disease. So that's great news. And is there anything else surgically that you would recommend for the patient?
So I would, given that this is a 62-year-old man, I would recommend that we complete an axillary lymph node dissection, and I'm assuming the margins on the primary tumor were negative. Okay.
Yes, great question. The margins look good. And so he's going to take your recommendation, but he's curious as to what side effects or what other long-term effects he can expect after an axillary lymph node dissection.
So the biggest concern would be lymphedema, and so prior to proceeding to the operating room, I would want to make sure I obtain a thorough baseline physical exam of both upper extremities. I'd also obtain impedance testing as a baseline beforehand, and have him see occupational therapy for fitting for a sleeve, and then I'm sorry.
Okay, great. Yeah. So then you take him to the OR, and when you do your ax dissection, can you describe a little bit about the operation, the critical structures, and what you're looking at or for?
Sure. So again, I would enter the axilla through the clavipectoral fascia. The critical things I'm looking for, or the borders of the dissection, would be the axillary vein superiorly, latissimus dorsi posteriorly, and then the serratus medially. I'd want to make sure that I identify and preserve the long thoracic nerve along its entire course through the axilla, and I would attempt to remove all fatty and lymphatic tissue within those borders.
Okay, wonderful. Is there any other neurovascular bundle or structure that you would look for as well?
So I'd also want to identify the lateral thoracic vessels and nerve and preserve those as well. If I can preserve the intercostal brachial nerve, I will. However, if it appears to be intimately associated with any concerning nodal tissue, then I would be able to take that, but I would try to preserve it if I can.
Okay, wonderful. It looks like we're close to time, I guess, but you did a great job. So if I could just say, so I think that I was just going to ask the next steps in the treatment plan, which you already went over, which was chemo, radiation, endocrine therapy. And I thought you really did a great job with the scenario. I know it's a little bit of a curveball, male breast cancer, but we treat male breast cancer the same as we treat women. There's just some small, nuances or differences. One thing is genetic testing. So I was going to get to that kind of towards the end as well. So I think for any cancer case, like you did, knowing when to do staging and knowing when to do genetic testing is really important. I know Dr. Cadan mentioned that sometimes they give you a lot of history, which was, which I think is kind of the experience. And when they do that, sometimes they still leave out things that are really relevant, like family history or, to kind of prompt you for these other things. But I thought you did a great job with that. I just not to get kind of thrown off by something like a subtle change. And then I don't know if it's fair for them to ask you chemotherapy regimens or where you would radiate or, about specific medical treatments, but that's something possible that could come up too. Yeah, but you did a great job. You got through everything. Just don't let them kind of trip you up or, make you second guess yourself. You were right to recommend surgery, and the way you walked through the operations I thought was really, really good. And like it was mentioned before, when you don't give them enough information of what they're trying to get, they will continue to ask you questions about it. So that's one way, you can, kind of plan what you're saying or plan, you don't have to necessarily give everything all at once. So I thought it was a great job. Thank you.
Thank you. Can I ask you a question,
Do
actually?
you have any feedback? Yeah.
In terms of managing his axilla, is there any role for talking about axillary radiation as opposed to axillary dissection for a male, or was it?
Yes.
We're
So
just doing a full axe dissection for him.
yeah, no, that's a great point. I was trying to not give too controversial of a case, so that's why I tried to give them 3 sentinel nodes, or maybe next time I should do 4. But yes, I mean, you could look at Amaros, and I think that's what you're referring to. If it, typically the way that we manage the axilla in a woman with breast cancer would be the same as a man with breast cancer. So I think if you mention something like that, like you could say that the options would be, to proceed with radiation or to consider additional surgery. And then they probably will tell you, or they might say, well, which do you want to do? And then you can say, I would do axillary radiation or I would do surgery or whatever it is. So sometimes I don't think it's bad to give the different options, but then they will push you usually to pick one and which way to proceed. So I was trying to get you to do the surgery because I wanted to make it really not controversial that he needed chemo, that he needed radiation, that, all of it. But you did a great job with that.
Thank you.
All right, thank you.
Thanks, Dr. Tashiomi and Dr. Chick. That's a really good session. And I think these answering mannerism and stylistic feedback and tips is really helpful for our audience. So thanks so much for the debriefing session as well. We're going to move on to the next case, and we have Dr. Patrick Georgia from Wakemed Hospital and Dr. Benjamin Hazen from Emory University.
All right, Benjamin, let's get started. So you have a 31-year-old male who presents via ground transport as a level 1 trauma following a motor vehicle crash. And per report, he was the restrained driver of a vehicle that sustained severe damage to the front end. And on arrival, the patient's heart rate is 130, blood pressure is 110/60, respiratory rate is 35, and oxygen saturation is 90% on a 9 rebreather mask. GCS is 13. How would you like to proceed?
So I would go see the patient, proceed with a primary survey showing that he is able to guard his airway, check bilateral breath sounds. We have our cardiac exam. We have our GCS and full exposure.
Yeah, so you do that, and on primary survey, you have an intact airway. You have decreased breath sounds on the right side. You have bilateral femoral pulses, and as I mentioned, a GCS of 13.
At this point, I'd place a 24 French chest tube on the right side. That was the diminished breath side. And then I would assess vitals, recess vitals after chest tube is placed, as well as monitor output from the chest tube, and then restart my primary survey, make sure that everything's still in line, and then start my secondary survey at that point in time.
Yeah, so you insert a chest tube, you get a small rush of air. The patient's oxygen saturation actually improves. Vital signs otherwise remain the same. Heart rate is 130, blood pressure 110/60. Respiratory rate has actually come down a bit to 28. Oxygen saturation is up to 96%. Secondary survey is notable for a seatbelt sign across the neck, chest, and abdomen. How would you like to proceed now?
Yes, sir. At this point, I'd like to use my secondary adjuncts. I get a chest X-ray, a pelvis X-ray, and a fast exam while ensuring that we have 2 large bore upper extremity peripheral IVs.
Okay, you have one 18 gauge IV that's working well, one 16 gauge IV, both in the contralateral upper extremities. Chest X-ray shows numerous right-sided displaced rib fractures and resolution, or excuse me, I should say a small pneumothorax with an appropriately placed chest tube. You have a pelvic X-ray showing an open book pelvic fracture. You do a fast exam and that is negative, and your nurses have sent off labs.
Perfect. Labs have been sent. I'd then place the patient in a pelvic binder. I'd also transfuse a unit of blood, watching for his hemodynamic stability.
How do you place that binder?
I'd place the binder under the, ensuring that the center of the binder is centered on the gator trochanters, and then tighten the belt as tight as I can, and then I'd shoot a chest, or excuse me, a pelvic X-ray afterwards, ensuring that the open book has been closed.
So you do that, and you do confirm that your pubic diastasis has decreased significantly with that in place. You mentioned you want to give a unit of blood. What would you like to give specifically?
If I would proceed with whole blood if we have it. If not, then I do 1 unit of PRBCs.
Okay. So you give 1 unit of whole blood, and the patient's heart rate improves some down to 120. Systolic blood pressure is now in the 110s.
Okay. Given that he is in my fast, I apologize.
Fast is negative.
Perfect. He is stable enough that I would proceed with a to the CT scanner for a pan scan with a very low threshold, that if he gets more tachycardic, more hypertensive, then I'd forego the CT scan and proceed to the operating room.
So CT scan shows resolution of a right hemopneumothorax. It shows pulmonary contusions that are pretty severe with multiple displaced rib fractures. There's a grade 3 liver laceration without any active extravasation, and a type 2 anterior posterior compression fracture of the pelvis. There's active extravasation and a moderate sized pelvic hematoma.
Okay. And his hemodynamics are unchanged?
Unchanged.
Okay. At this point, if I could proceed to IR, if they're readily available, I would proceed there given his stable hemodynamics. If that was unable to be done in a timely fashion, I'd proceed to the operating room.
Okay, so IR is in a case right now. They should be ready in about 30 to 60 minutes.
Okay. At this point, I'd transfuse another unit of blood, watch his hemodynamics, and hopefully, wait 30 minutes if they're available.
Yeah, pressure drops in the interim, despite that extra unit of whole blood.
Okay. At this point, I proceed to the operating room, and I would perform preperitoneal packing around the pelvis. I'd make an incision below the umbilicus, develop my preperitoneal plane bilaterally, and stick 3 or 4 gauze trauma pads preperitoneally on both sides, while keeping the binder in place, and monitor my hemodynamics.
Excellent. And if you do this, you said you left the binder in place. Is that correct?
Yes, sir.
Okay. And what if the patient remains hypotensive despite preperitoneal packing?
At this point, I perform an upper midline laparotomy, and to evaluate the stomach, or excuse me, the liver and the abdomen, to ensure that I don't have ongoing bleeding from the liver.
So you have a laceration to the right lobe of the liver that has some venous bleeding. How would you like to address that?
I'd pack all the areas, then I'd sandwich the liver between some pads. I would hopefully give my anesthesia time to catch up. I'd activate MTP. I would have, when the patient dropped the blood pressure, I've activated MTP with 1-to-1 transfusion. I'd pack the liver, let the anesthesia team catch up. And if afterwards I'd unpack, looking for any signs of bleeding, whether I use topical hemostatics or chromic stitches to stop any obvious bleeding in the liver.
And despite this, the patient remains hemodynamically unstable. They're getting massively transfused by the anesthesia team, and you have a growing pelvic hematoma.
Okay. At this point, I would place a femoral arterial line and prepare to proceed with a Roboa.
How do you place a Roboa?
So using an ultrasound, access the common femoral artery, using fluoroscopy and Roboa kit and contrast with dye. I would advance the Roboa to zone 3, assuming that the liver was no longer bleeding, and inflate the balloon under fluoroscopy.
Now, let's say that the patient did not get unstable. You did some preperitoneal pelvic packing. You take them back the next day, and they look good. But 3 days later, they develop signs of septic shock. Are there any etiologies you can think of?
For septic shock, either this could be infectious, this could be hematologic, hemorrhagic shock. I would do EKG and ultrasound, ensuring this is not cardiogenic. But my primary,
those are all unrevealing, no signs of bleeding. Again, it looks like septic shock. You take a look at the wounds and you're worried about a wound infection, as well as some crepitus in the perineum.
Okay. So my concern for necrotizing soft tissue infection is very high. If the patient is still hemodynamically unstable or intubated, I would perform a incision and drainage at the bedside to assess for a necrotizing soft tissue infection. If this was concerning,
so the patient has a necrotizing infection, what do you think the source could be?
From my open book fracture and a missed taloviscus injury.
All right, so we'll wrap it up. So I was looking for at the end, there's just a long shot for rectal injury. And so we didn't give you any hints or tricks on that or tips on that one earlier. That was just kind of, you're doing too good. So I had to throw something in there. So you did a great job. All the classic, you did great in terms of this classic kind of trauma scenario. I think it's a good idea, like you had, is to have a fixed response when you start about that primary, the secondary. In fact, I think you can throw in primary, secondary, chest, pelvis, fast, et cetera, get all your adjuncts, primary, secondary, all together, and then you get all that information up front, and you can move forward to the meat of the scenario, which is going to be your decision making and management, which will essentially be in the trauma bay. One of two things: you're either going to go to the CT scan or you're going to go to the OR. And so I like how you place that chest tube right away. That's the appropriate thing to do here. You mentioned blood. Blood is best for bleeding patients, of course, and so I like that. You should always. You mentioned access. It would be always a good idea to mention massive transfusion. Just say that word in a patient like this who's bleeding. If at any point you think that's appropriate. The decision to go to the CT scanner on a trauma scenario in real life is challenging, right? What is stable, what's not? I think this patient was certainly well within the realms of stability to get to the CT scanner, and that's why we didn't give me any trouble with that. Be very careful on the boards about getting yourself in a situation in which the patient becomes unstable in the CT scanner. But I think this was highly appropriate in this case as well. Take him to the OR without waiting around for IR. That's appropriate. You described preperitoneal packing well. You had earlier described how to bind appropriately, also double checking to make sure that space has been closed off with a repeat chest x-rays, or pelvic x-ray is always nice. And appropriate management then of pelvic trauma. And when things weren't going your way, extending into a laparotomy, which is appropriate, especially in the finding of a grade 3 laceration and a high energy mechanism to ensure that you don't have any injuries in the abdomen. So that was a good move as well. And then after the fact, you have multiple different ways to deal with a bad ongoing bleed from the pelvis. 85% of these bleeds are venous, but if you catch one of those 15%ers and it's arterial, packing may not do the trick for you. So a Roboa plus IR can save you some time, as you mentioned. Be ready. We have to be very familiar with Roboa if you bring that up on the boards. Although I think this day and age, it's something that is accepted as an adjunct in these scenarios. The other way would be to dive into that pelvic hematoma, which would get tricky, but you'd need to be able to describe, controlling the hypogastric artery would be kind of what you'd be going for, and either empirically ligating or ligating whatever the bleeder that you find. This case didn't have it. Again, I just threw it at the end, but anytime you have pelvic fractures, make sure you think real hard about the bladder, urethra, and any rectal injuries. Again, in a scenario like this, you would get something. You'd get blood on rectal exam, you'd get CT findings, or external trauma, peritoneal trauma, etc., to be able to set you up in a situation like that where I just pulled out of the blue, but you're doing too good. So I thought you did a great job.
Thank you, sir.
Thanks, Dr. Georgiev and Dr. Hazen. It was a good session. And Dr. Georgiev, I think it's a question in the Q&A about Reboa. You alluded to it in the debriefing, but maybe you can expand a little bit in the Q&A. We'll move on.
The question I can't see.
I think it's in the Q&A. There was someone who, either Nora mentioned that they wouldn't place the Reboa here at all, would go after enlarging hematoma. Is that not the right thing to do?
They said they would not place Reboa?
Yeah, and they would go after the enlarging hematoma instead.
Yeah,
so
yeah,
be a reasonable thing to do.
Yep, those are all different options depending on whatever you're comfortable with, and I think that would be very reasonable, of course.
Perfect. All right, so we'll move on to the next case, and we have Dr. Jenny Shao from UPenn Medicine, and the mock examinee will be Dr. Bradley Kushner from WashU. Dr. Shao, I think you're on mute or the mic isn't working. Perfect.
Okay, sorry. Welcome, Dr. Kushner. So today you're in the outpatient setting. You're going to be seeing a 68-year-old female. She's presenting to you with complaints of nausea, vomiting, dysphagia, some early satiety, and some reflux symptoms. She also notes intermittent regurgitation. She has a past medical history of hypertension, diabetes, hyperlipidemia, and her past surgical history is she's already had a laparoscopic cholecystectomy and a previous hysterectomy. So this is your patient. How would you like to proceed with her workup?
Perfect. I would go ahead and start seeing the patient and start with a detailed history, looking for the length of symptoms of the dysphagia, heartburn, and other GERD-like symptoms she's been having, as well as any lifestyle changes. And I would also focus on any red flag symptoms like weight loss, bleeding, odonophagia, or chest pain or anemia.
So she says that the symptoms maybe started over the past year. It's gotten a little bit progressively worse. She does have some dysphagia, mostly with solids, but not really any liquids that she's noticed. But really, she just feels really uncomfortable after she eats, and she feels very full. And then quickly afterwards, feels like she has to have nausea, vomiting. She doesn't have any other signs of bleeding or any of those other symptoms that you had mentioned.
Great. And any family history of any upper gastrointestinal disorders?
No.
Okay. And then I would go ahead and proceed with a physical exam.
So her physical exam is largely unremarkable. Her
Perfect.
vitals are stable, if you're wondering, and her BMI is about 30.
Great. And then going back to the history, has she tried any PPIs or any other types of lifestyle modifications?
Yeah, so she's been on a PPI long-term for the last 20 years. She notes that it helps sometimes, but she still does have reflux symptoms and she still has regurgitation.
Great. So at this point, I would go ahead and start with my workup, including basic labs, a CBC and a BMP. And then I would also start with a barium esophagram and an EGD if she's not had one recently.
Okay, great. So your lab work is largely unremarkable. Her hemoglobin's 11, but otherwise everything looks fairly stable. Her endoscopy shows a moderate-sized hiatal hernia and notices some Cameron's ulcers, and her upper GI shows probably a moderate to large-sized paraesophageal hernia.
Great.
Is there any other additional workup you would like at this time?
Yeah, given the fact that her barium upper GI and her EGD was concerning for paraesophageal hernia, I would go ahead with manometry as well, and then ask to see the patient back in clinic to talk about the results.
Okay, so you asked her to get a manometry, and as they're doing the tests, they find that they're unable to pass the manometry catheter due to the size of her hiatal hernia.
Great. And then Are they able to do that during the EGD as well, to place the catheter?
Yeah, so they try again, and you really can't get a good manometry just because of the size of the paraesophageal hernia.
Okay, so at this time, I would bring her back to the clinic, and I would discuss that given the fact that she has Cameron's ulcers as well as significant symptoms that are associated with paraesophageal hernia, I would offer her surgical intervention for her paraesophageal hernia, namely a laparoscopic paraesophageal hernia repair. And then given the fact that I wasn't able to get preoperative manometry, I would consider doing a partial toupee wrap.
Okay, perfect. That sounds great. So let's change the scenario a little bit. So what if this patient had a BMI of 40? Would you counsel her the same way, or would you pick the same operation?
So no, that's a really good point. I would definitely counsel her for the fact that the biggest risk factors of paraesophageal hernia recurrence is obesity. I would talk to her about other options for weight loss and surgical weight loss, including Roux-en-Y bypass, and that would also help to fix her GERD, as well as we could do a hernia repair at that time as well.
Okay, perfect. Okay, so let's say your patient still does have a BMI of 30. So can you walk me through the steps of that operation?
Sure. So after gaining safe abdominal access, I would go ahead and take down the gastrohepatic ligament to the right crus, and then encircle the anterior esophagus, making sure to protect the left vagus nerve. Then I would take the short gastrics down, do the same on the posterior side of the esophagus, protecting the right vagus nerve. I would work on my esophageal mobilization, reducing the entire hernia sac. I would excise the sac, close my curl stitches, and then work on my wrap.
Okay, great. What kind of wrap did you decide to do?
For her, unfortunately, since we weren't able to get preoperative manometry, I would stick with the partial toupee, probably the posterior 270.
Okay, great. So you do the operation. She does really well intraoperatively. You have no acute concerns. You are rounding on her on post-op day 1, and you note that she's had some nausea, vomiting, retching overnight, and she feels really uncomfortable and has some chest pain. What would you do to work that up?
Yeah, so I would first go see the patient, of course, get a quick history and vital signs on her. And I would certainly go from there. Mainly in the history, I would look for whether she's had any actual vomiting, or whether I was feeding her at the time, or whether these are just subjective symptoms that she's feeling.
Gotcha. So what's on your differential as I'm mentioning these postoperative symptoms?
Well, certainly a leak is, what I would be most worried about, or an esophageal injury at that time. Other things on my differential, more benign pathology, would just be some edema from the wrap early on, and postoperative swelling. Those would be the main things I'd be worried about. And of course, any of the postoperative complications that are scary associated with chest pain, like acute coronary syndrome, lung pathology, PEs, or any other things that can happen with any type of surgery.
Okay, great. So let's say that, she's pretty stable. You decide to get an upper GI, and it shows that she has a really early postoperative recurrence. What would you do at this point?
A fairly large postoperative recurrence?
Well, you see that half the wrap is back up in the chest.
Okay. Well, given the fact that she's pretty symptomatic and she has an early recurrence, I would certainly consider taking her back to the operating room for a repair.
Okay, perfect. So let's change the scenario again. So say she does really well post-op, no acute complications. You see her 1 month post-op in the clinic, and she has dysphagia. What would be your next steps?
Well, I would take a history and find out exactly what she's been eating and what kind of food she's been eating, and whether she's been sticking to mostly a clear fulls, and had a relatively normal progression. Assuming that she has kind of followed my postoperative guidelines, I would certainly be thinking that the wrap that I made was too tight, or if I did decide to do a full 360-degree wrap, that she wasn't able to tolerate that.
Okay, perfect. Let's end the scenario there. Do you have any questions for me?
I don't think so.
Okay, great. So I think you did really well in the case. I think you had really good progression throughout the case, and I think things moved along quickly. The only feedback I really have for you is I would probably fast forward through her history and physical just a little bit, because I think in the beginning of the scenario, I had given you most of the relevant information. So I don't necessarily think you have to spend as much time asking about the family history or some of these other things. I think I understand that you're trying to be thorough, but when the examiner gives you the bulk of the information, I don't think you necessarily have to, go and do that. But I think your workup was really appropriate. I think getting the upper GI, the endoscopy, asking for the manometry, those are all like really important parts. And then I think when you couldn't get the manometry to do the partial fundiplication is exactly right. So you'll notice I changed the scenario on you multiple times. So that happens throughout the exam. And so a lot of times, this happens a lot with appies, right? Say like, oh, it's appendicitis, but now it's like appendiceal tumor at the tip. Now it's at the base. And so I think you did really well when the scenario changed, especially when I asked you if the BMI of the patient was higher, what would you do? I think it's really appropriate to say you would counsel her for bariatric surgery and do a Roux-en-Y gastric bypass versus a fundiplication. I think that was done really well. And then I think you described the procedure really well. I think the only technical part, just because I'm a foregut surgeon, is you probably really want to talk about, that this is going to be a hernia sac dissection, right? So you're mobilizing the hernia sac off of the esophagus and the anterior crura. So, but honestly, that's just like a very technical point, but I think you did a really good job describing the procedure. And then of course you have all these potential post-op issues that can occur. So I think you are right to obviously go see the patient to figure out what you do from there. And a lot of times, you can have a post-op recurrence that's early. And if they're symptomatic, you're right, you go back to the operating room. Other things that they may ask you is, well, now that you're back in the operating room, what would you do differently this time? I think some of the things you can do are, well, like, what was the reason for the hernia recurrence? Like, do you need to put additional sutures? Do you think about putting an absorbable mesh? Do you think about doing a gastropexy? I think those are all things that you can consider. And then of course, with any foregut case, you can always have an esophageal leak. So I think your mind was right when you said, oh, like if you're worried about a leak. So definitely that's what you can do. Sometimes on the exam, you can also say that you would do an intraoperative endoscopy at the time of your operation, just to make sure that you don't see anything intraoperatively. Even if your endoscopy looks good, they can still throw you a leak. So that doesn't preclude that from happening, but at least, that's something else that you can consider. Okay, but overall, great job.
Thank you very much. I appreciate your time.
Perfect. Thanks so much, Dr. Shaw and Dr. Krishner. We'll move on to our next case, which is a vascular case. And we have Dr. Caitlin Hicks from Johns Hopkins Hospital, and we have Dr. Alexis Loria as a mock examinee from Walter Reed Medical Center.
So you're
I'm sorry, I'm having a really hard time hearing you.
Yeah, I think Dr. Hicks is having some connectivity issues. I wasn't hearing it well as well. Why not let's do this? We will move on to the next case while we work the technical issue out, and we'll have Dr. Hicks back in about 10 minutes. So in the meantime, Dr. Laura, if you hang in there, we'll move on to the supposed final case, which is a pre-recorded session. It's an endocrine case between Dr. Timothy Reeland from Walter Reed Medical Center as well. Brooke Army Medical Center, and Dr. Sasha Mavi from Brigham and Women's Hospital. So this is a pre-recorded session. I'll share my screen and I'll play the video.
Yeah, let's do it. All right, so your next patient in clinic is a 43-year-old female who's been sent to you by her primary care provider because she felt a thyroid mass on routine physical exam.
Okay, great. So I would ask the patient any family history of any thyroid or endocrine disorders, any history of neck radiation, and any compressive symptoms that she might be having.
Okay, so unfortunately she's adopted, so she doesn't know her family history, so nothing she's aware of. She really had no symptoms. This was just found on a routine physical exam.
Great. And any history of neck radiation?
No.
Okay. So then I would examine her neck.
Okay, so if you really go for it, you can feel a small nodule on the left side. It's it's not fixed or anything. Everything moves when she swallows. You don't feel any lymphadenopathy.
Okay, great. So I would send the patient to get a neck ultrasound, and I would draw a TSH.
Okay, her TSH comes back as normal. She goes for her neck ultrasound. They say there's a 2 centimeter solid nodule. No lymphadenopathy on the comprehensive neck ultrasound, really no other findings on the ultrasound.
Great. I would request then, since it's 2 centimeters, to do a FNA of the nodule.
Okay. So they take her down for an FNA, and they're about to do the biopsy, and they check her vitals, and her blood pressure is like 230 over 150. So they cancel her ultrasound guided biopsy, send her back to you.
Okay. That's a little high. Does she have any history of hypertension that we know of before this?
Yeah, she's on an ACE inhibitor for hypertension. It's fairly well controlled with that.
Okay. So I guess my concern is that she has some sort of underlying disorder causing her blood pressure to be higher than normal. So the next test I would think about getting is plasma metanephrines, since she has a thyroid nodule, to rule out a pheochromocytoma.
Okay. You send her down for plasma metanephrines, and it's slightly elevated. It's kind of borderline high.
Okay. In that case, I would get 24-hour urine metanephrines and normetanephrines.
Okay. Those are elevated.
Okay. So at this point, a patient with a thyroid nodule and biochemical evidence of pheochromocytoma, my concern is that she has an MEN syndrome. So first thing that I would want to do is deal with the pheochromocytoma. So my next test would be a CAT scan, the abdomen pelvis, to try to localize it.
Okay. She, on CT abdomen pelvis, she has a 2.5 centimeter heterogeneously enhancing nodule on the left adrenal gland. No other findings that are relevant.
Okay. Then my next plan would be to medically optimize her with alpha blockade. She's already on a beta blocker, which needs an alpha blocker. Then plan for a laparoscopic left adrenalectomy.
Okay. What kind of alpha blocker are you going to use, and how are you going to titrate it?
So I would use either phentolamine or phenoxybenzamine. I think one of them, the price went way up. I forget which one. And I would titrate it till her blood pressure is normal in the 120s.
Okay. All right. So she has normal blood pressure when she comes to see you after 2 weeks of blockade. Any other symptoms that you would look for to tell you that she's appropriately blocked?
I don't know.
Okay. And then she's kind of appropriately blocked. What do you want to do next?
So then I would take her to the OR to do a laparoscopic left adrenalectomy.
Okay. So anesthesia is this patient in the operating room. What do you think they should have ready for the OR? And can you talk specifically about your kind of coordination with them in the operating room?
Certainly. So I think this patient should have good peripheral IV access during the case. Should have an arterial line for continuous blood pressure monitoring. During the initial part of the case, I would suspect, oftentimes, especially with manipulation of the adrenal gland, that the blood pressure could be quite high. So I'd have them have nitroprusside ready as first-line antihypertensive. I would be in close communication with them as soon as I clip the inflow and outflow to the adrenal vein, as the blood pressure can drop precipitously at that point. So I'd want them to have the patient adequately fluid resuscitated at that point with pressors ready to be given.
Okay. And when you start the case and you visualize the adrenal gland and everything, how are you going to approach the gland? what are you going to do first?
Sure. So I would have the patient up in a right lateral decubitus, flex the bed, varus entry, place my ports. I would have to take down kind of splenic flexor, mobilize the colon, get back to within Gerota's fascia where I find the left adrenal gland. At that point, the left adrenal vein should be able to be visualized, crossing over. And then the left adrenal arteries, you often can't. I would take the vessels all with laparoscopic ligature during this time.
Okay, so let's go back one step and say on your CT scan, you weren't able to visualize anything. What would your next step for localization be?
I would get bilateral adrenal vein sampling with IR.
So describe how you're going to do that.
I would refer to my IR colleagues who would get venous access through the femoral vein, presumably, and then they would sample left and right adrenal vein or renal vein to.
Any other imaging studies that can be used to look for adrenal, or I'm sorry, for PHIOs if they're not seen on CT scan?
I guess I don't know specifically. I would have to look up if a PET scan could be indicated for this.
Okay. All right, so let's say you do your PHIO, everything goes great. Now she wants to know, what about this thyroid nodule? What are we gonna do about that?
So then at this point, we still don't have a diagnosis. So did her, sorry, I think did her RET, did I get RET tested?
Yeah, so she does have she is positive for a RET proto-oncogene mutation.
Okay, so then I would biopsy, or sorry, FNA the thyroid nodule.
Okay, what do you think it's gonna be?
It'll probably be medullary thyroid cancer.
Indeed it is. How are you gonna manage this 2-centimeter medullary thyroid cancer?
Well, you said on her ultrasound she had no nodes. So the next thing I do is I check serum calcitonin, CEA, calcium as well.
Okay, so her calcitonin is slightly elevated. The rest are normal.
Great. Then I would consent her for a total thyroidectomy and central neck dissection.
Okay. What are the risks of a central neck dissection that you discuss with the patient?
So I would discuss that in addition to the normal risks of a total thyroidectomy, including recurrent laryngeal nerve injury, hematoma, and permanent hypoparathyroidism, that there's an increased risk of a lymph leak from injury to the thoracic duct.
Okay. All right, good. That's about time. Okay, so that was 7 minutes. So yeah, good. I mean, I think that scenario is one that everybody should be ready for, right? The PHIO. So a couple things. I teach all my residents anytime they have a thyroid nodule to just check a calcitonin because they may just give you, oh, the calcitonin's elevated, and then you're kind of in that frame of mind. So before you send the patient down for biopsy on the oral boards, not so much in real life, but on the oral boards, I would just check a calcitonin. So I think checking calcitonin is just sort of playing the game for the oral boards, even though you probably wouldn't do that in real life. And then, you know, the other thing is once you have the diagnosis, or once you're concerned about a PHIO, you got the red proto-oncogene, that was good. I think, you know, you kind of pick that stuff up. Imaging, so you got CT. If that's negative, the things you can do are, the old school is an MIBG scan. Nowadays, a dotatate PET. So you mentioned PET, which is correct, but a dotatate PET. So PHIOs actually light up on dotatate. So if it's like at the organ of Zucker candle or some weird location, which is more common, right, in the familial scenario than in the sporadic. So the dotate's helpful. The other thing, pre-op. So you're going to alpha block. The like old Abside answer is probably phenoxybenzamine. And you know, nowadays we usually use Cardura. The reason being, Cardura is a selective alpha blocker, so it blocks only alpha 1, so you don't get as much reflex tachycardia. So it cuts down on the amount of reflex tachycardia you get. So that's generally what people use now, is a long-acting selective alpha blocker, with Cardura being the most common one. And then your goals for blockade, like you said, normal blood pressure, yes, but typically what you do is you push them to the point where they have a little bit of postural hypertension. You want to hear that they're like a little dizzy when they stand up, and then they should have a runny nose too. So rhinorrhea is the other indication that they're adequately alpha blocked. Again, these are kind of minor things that'll impress the examiners, not that you need to get them on the oral boards, but, and then the other thing that you really should do pre-op is salt load them in some way. So you can do that as an outpatient, just tell them to eat a really salty diet for a few days before surgery, or some people would admit the night before and load them up with saline. Just like you said, I think you mentioned in the operating room, you'd want them to be well hydrated for when you take the vein and, they stop getting that, their blood pressure is going to drop. You want to be hydrated. So you just kind of do that pre-op and get them ready. I think those were the big things. Otherwise it was good. Your, management of the medullary was fine. Total with central neck. The other thing, mentioning the chyle leak is reasonable on a central neck, but the risk of hypoparathyroidism is actually quite a bit higher with a central neck than just with a total without that. Because if you think about, everything in the neck you're going to take that looks like a lymph node, that kind of often includes the paras, so you got to be real careful about preserving the paras when you do a central neck dissection. But overall, I think it was good. Certainly a passing run through. And again, I think the way I would approach the oral boards is try to have a few scenarios where you're going to just nail them. And I think for, somebody who wants to do surg-onc, you're sort of going to hear about this stuff anyway. And then those should be kind of the scenarios you're going to nail, because you're going to get a thyroid, you're going to get a breast. There's these couple things in the onc world. I assume you're going to do surg-onc, or maybe I'm just making that assumption. Yeah. So, that's the way I kind of approach it. Is I pick the things that I'm interested in anyway, that I knew I was going to get. And I said, I'm absolutely going to nail these questions. And then the vascular stuff, I didn't know that much about. I just knew enough to pass. So, because you do want to do sort of above and beyond on some of the questions. You certainly don't need all of them, but you want to be able to impress the examiners in the room, I would say, with one per room ideally, because really the way they score it, they do score you per question, but it's kind of a composite score per room. And so if you nail the men one, it's going to give you confidence for the other ones in that room. And two, it's going to make the examiners think, oh, you're going to pass.
Perfect. So I think we're going to move on to our final case, and we'll have Dr. Caitlin Hicks again and Dr. Alexis Lauer.
Yeah, can you hear me okay now?
Yeah.
Great. Okay, so you're called down to the emergency room to evaluate a 34-year-old female. She was walking on the curb of the street with her friend, and she felt her knee pop when she fell off. It's already evaluated by the trauma team, and as you're told, she has an obvious right knee deformity, and her right leg is cooler than her left.
Okay, great. So I'd head down to the emergency room. I would confirm that the trauma team had kind of done the appropriate trauma workup, including her ABCs, gotten some access, and a thorough evaluation of all other injuries. I then would begin my exam with a focused pulse exam on that limb, also comparing to the other side to see if there's any pulse discrepancy.
So she has no other injuries except for this obvious right leg problem. She's complaining of pain in the right leg. She's got easily palpable femoral pulses bilaterally, and then palpable popliteal DP PT pulse on the left, but no palpable pulses on the right below the thigh.
Okay, and just for thoroughness sake, I would do a very quick ABI to compare the difference.
Tell me how you do that.
So I would get a blood pressure. I would use a Doppler and a manual blood pressure cuff and assess the pressure in each extremity, and then compare the highest of the two in the affected limb, and then the highest of the upper arm pressures.
Which arm do you use for that?
The highest of the two.
So you're measuring both arms?
Yes.
Okay. So you do ABIs, and she's got her ABI of 1 on the left side, and on the effective side, it's 0.2.
Okay. So at this point, and kind of given the history, I'm concerned that the posterior or the knee dislocation has caused an injury to the popliteal artery. Does she, and then I would continue with a more focused motor and sensory exam to assess the extent of her neurovascular injury.
She can't really move her leg because she does have an obvious knee deformity and just is in a lot of pain.
Okay. And she's otherwise hemodynamically stable, and I know you'd mentioned she didn't have any additional injuries.
Yes, no additional injuries, and she's otherwise stable.
And the trauma team's done with their kind of evaluation of her.
Yes.
Okay. If I were in a center where I could get a CT within a relatively quick amount of time, I would get a CTA just to understand her anatomy, the location of the injury, and help with my planning. If that was going to take more than 15 to 20 minutes, I would plan to proceed to the operating room and do a diagnostic angiogram on the table to get a kind of characterize the injury and then plan my procedure.
Is there any other input or thing that you'd want to do before you did that? Either of those steps? Any other team to call?
Yes, I'd want the orthopedic surgery team to evaluate her knee dislocation and plan for the repair.
It's orthopedic surgery sees her in the ED, and they repair that dislocation. So they put her back into inline orientation. Anything you want to do next, or just go straight to CT?
Yeah, so then I would reassess her pulse exam to see if the kind of realigning the joint improved her pulse distally.
Okay, and how are you going to do that?
So I would do, since she didn't have pulses, I would do a Doppler exam if that, and also reevaluate to see if they had become palpable, and then repeat my ABI.
Okay, so she now has an ABI of 0.7 on the right.
Okay, so that would reassure me. I think given that, I would want to then go ahead with a CT angiogram again to just assess if the injury caused any distal emboli, or see what kind of injury there is after they've relocated the knee.
Okay, so you do a CT angiogram and it shows intact flow with 3-vessel runoff, but she does have a focal dissection in the middle of the popliteal artery.
Okay. And her pulse exam and her motor sensory exam is the same as it had been.
She's still in a lot of pain. She can move better now that her knee has been realigned, and she mostly has sensation. Although maybe a little bit on the dorsum of the foot it's lacking.
Okay. How extensive is the dissection?
It extends pretty much the behind knee popliteal artery.
Okay. And all of her distal flow is intact. So because it's like across a joint, I don't think this would be a lesion that I would want to treat endovascularly. And because she now has improved flow, I think I could safely manage her with antiplatelet for the dissection.
Okay, so you decide to put her on antiplatelet therapy, and ortho takes her to the OR for an X-fix. And when they're finished their X-fix, they call you because her foot has become pale again. Okay,
so then I would go in the operating room, reassess her pulses, and plan for a diagnostic angiogram to reevaluate the injury.
You have a similar pulse exam to before. You have a multiphasic signal on the right leg, but when you perform your diagnostic angiogram, there's clearly a flow-loading dissection in the popliteal artery.
Okay, so I would plan for a open bypass of the affected area. I would do a medial approach. Have her, so she had been presumably positioned supine by the orthopedics team. I would kind of externally rotate and bend the knees slightly, kind of based on how they had their X-fix. And then I would approach the above and below knee popliteal artery and plan for a bypass with vein.
What conduit were you going to use?
Contralateral vein, if it's available.
What type of vein?
Like her autologous vein.
Saphenous, femoral.
Saphenous vein.
Okay. All right, so you finished that. Anything else at the end of the procedure you want to think about before you wake her up from anesthesia?
Yeah, so I'd want to do a completion angiogram. As I hadn't mentioned earlier, I would have left my sheath from the diagnostic in so I could take another picture at the end, and then also reassess her pulse and signal exam.
Your completion angiogram looks good, no issues. She's got a much improved pulse exam. Anything else to think about before you wake her up?
So there's no evidence of any distal emboli that I would need to thrombectomize. She's got improved flow. My anastomoses are intact. I might be missing something obvious, but I'm not sure.
Say I told you that it was 8 hours since when you finished your bypass.
Yeah, so if she had been ischemic for at least 6 hours, but I think more recently the evidence would say even less than that, I would perform 4-compartment fasciotomy.
I think we can end there for time's sake. So good job. I think you sort of just missed some like basic steps and just time to take a step back to just think about it. you had it all there, and sort of with a little bit of prompting, you're able to get there. So I think all in all, if you're able to sort of redirect yourself when the examiners are giving you a little bit of clues, that's a sign that you know the information, you're just sort of not processing it perhaps as organized as you perhaps could be. So I think this is a really common scenario on the oral boards. And so just sort of getting it down. Obviously you need to get the knee realigned and then reassess the pulses before you decide to do anything. Imaging is good. You had sort of the plan to do on-table angiogram if the CT wasn't working, because that's a common thing that they'll give you, like, oh, the CT's not working, so what do you do? Anybody that's in their low 30s with an ABI of 0.7 and the other side is palpable, I would never just watch it. You should just go and plan to go ahead and do something. But as you had a recommended antiplatelet therapy and sort of were given the expected scenario that that didn't work out for her. But just sort of, I would not plan to not do anything. This is a surgical oral board scenario, and likely that you're being led to sort of intervene.
Yeah, as I was saying that, I was like, I know this is not the right answer. I was thinking about dissections elsewhere. So like, even with improvement, there is no endo approach to this, certainly not for like general surgery mock orals that you would, there's no sense that you'd put across a dissection.
So in general, endovascular interventions are totally fair game on the oral boards, but not, I would say, not controversial ones. So for the general surgery oral boards, I would not be putting a stent in the popliteal artery. If you do, you would want to be very clear that, like, you're doing it should be some high risk patient. There's some obvious reason why you can't do an open repair. And then you'd want to make it very clear that this is probably a temporizing situation and you don't expect it to maintain patency. I would just go for the safe answer, which is an open operation, because popliteal stents are not considered safe.
Right. And then like the right progression would have been, like, even though so they realigned it, improved a little bit, ortho takes her eye, plan for diagnostic angio in the room, and then just go with that, like, plan for surgery.
Yeah, I mean, I tried to make the ABI not subtle, but no one's going to give you an ABI of 0.9 where that's like a little bit unclear. But up an ABI of 0.7, it's clearly diminished. I mean, you're well below where you should be at the age of 34. So almost certainly that needs treatment. If you want to get another imaging, you could do a duplex to see if there's like flow imaging or an on-table angiogram, because that'll give you the sense of sort of flow in relation to the dissection, which CT angiogram does not give you.
Got it. Awesome. Well, thank you.
Overall, good job. Just, really just sort of work through, make sure you go through the steps, but you did a good job sort of stepping back and sort of realizing your mistake and fixing those. And that's what it's all about.
Thanks, Dr. Hicks and Dr. Laura. That was a really good case. And Dr. Hicks, I know you're an airport, just got off a plane. So just for convenience and ease of everything, there was a question in the Q&A. Will we be told if we are vascular trauma in the scenario, or will we be answering as a county general surgeon having to be vascular?
Every scenario could be a little bit different. So I chose to I wanted to move past all those steps of doing the trauma evaluation for this scenario. I didn't want to spend time on that, which is why I gave her the fact that she was on trauma and it had already been done. But it'll be made clear to you sort of how much has been done. Nobody's there to trick you. It'll be obvious when someone gives you a scenario.
Perfect. Thank you again. I know you just got off a plane, so I hope everything went well.
Thank you.
Thanks for your commitment. So that basically caps off our bots mock scenario webinar, and a reminder that these sessions are recorded and will be posted on the SSAT Residence Corner website for future viewing. So to close, I'd like to thank all our speakers and mock examinees who took the time out to be here today. It's not easy volunteering to be a mock examinee in front of a national crowd, but you did it and you all killed it. And specifically, I'd like to thank Maria Altieri, who is our committee chair for leadership and on our committee and for leading the webinar efforts as well. But most importantly, we'd like to thank Beverly Hendry, who's our Director of Administration, who does all the behind the scenes dirty work alone and somehow managed to keep everyone and every committee member in check. And this doesn't happen without her. And lastly, Dr. Lexi Adams, who was supposed to be a moderator for this session, she was the one who herded all the surgeons and the residents to get on one date and time. And that's not an easy task, as you can see. And she couldn't be here because she's in an OR right now. So good luck on your boards, and thank you everyone for tuning in today. Good night.